today with Dr. Frank Veith, chairman of the 40th Annual VEITHsymposium. And we're here today to talk about carotid disease, which is still one of the primary causes of stroke. Out of the 750,000 strokes that occur each year, probably 70 to 100,000 of these strokes are related to carotid disease. 4 sessions here at the VEITHsymposium, a lot of new information, a lot of new data. And Frank, what have you seen of highlights from these sessions?
Well, I think the big highlight is it's still controversial. I mean, how symptomatic and asymptomatic carotid disease should be treated. There's been a lot of new information that I've heard. I think one of the most exciting things is that more direct evidence that medical treatment with statins, which have been demonized in the lay press and to a certain extent in the medical press or medical media, that statins can actually stabilize and even shrink arteriosclerotic plaques. I didn't know that. I'd heard hints of that before, but to see the direct evidence that measurements now have documented that, and that the higher the dose of the statin, the lower the LDL, the more the shrinkage occurs and the stabilization occurs. That to me was new. And of course your presentation that CREST-2 has been approved and presumably will be funded, I think is a major advance, because that's going to answer questions about what constitutes the best treatment for asymptomatic carotid disease.
I think that was an important kind of trend that we've seen over the last couple of years. Technology really came in about a decade ago with carotid disease, and we didn't hear too much about medicine. And now we're getting the medical side.
But on the other side of the equation, the other side of the coin, is that even though carotid stenting has undergone somewhat of a diminishment of its popularity, we heard yesterday that there are many improvements in carotid stenting that may reinvigorate it and make it a more effective and safer treatment. And specifically the work about the new stents, reversal of flow, better access through the neck as ways of making carotid stenting safer. I think carotid stenting has gone up to a peak, it's come down a little bit, and I think it's going to rise again. That's my opinion.
Yeah, one thing that was encouraging to me as part of the CREST trial, that we had such good results despite having so many centers, 117 centers, which I think says something about the technique.
Well, I think it also talks to the issue that people shouldn't be doing a procedure who might not do it optimally. And I think one of the problems with carotid disease is that the carotid artery is very easily accessible, it's very attractive to treat in many ways, and as a result, some individuals who may do it not as a specialty but as somewhat of an adjunct to their practice and not do very many procedures are tempted to do it, and that of course leads to results that aren't as good with some individuals doing it as it is in a center that's devoted to it. And I think CREST proved that. You had people doing carotid stenting who were committed to it, were vetted, and did it very well, and as a result your complication rate was lower than it was in other centers.
One of the themes has been finding the right patient. You know, that's been kind of a challenge for a while. And where do you think that's going?
Well, one of the ways to get, this is a pet issue with me, one of the ways to get good results in any interventional or surgical procedure is to do patients who don't need it and have a relatively benign disease. And that's certainly true with carotid stenting. So I think if one is going to treat patients that really needs the treatment, it's acceptable to have a adverse event rate. Whereas if one's treating patients that don't need to be treated, then it obviously isn't acceptable. But the other side of that coin is you get very good results if you treat patients that have minimal disease.
One of the issues with the statins, you've mentioned the long term. We have pressure now from the interventionists and the surgeons in CREST too to treat people with high-dose statins before they get the procedure. You know, in other words, a short-term type benefit of statins. What's your view on that?
I'm totally supportive, because I think the evidence, and we heard some new evidence today at the last session, I don't think you made it there, that statins, particularly in high dose, in the peri-procedural area, will diminish the complication rate of whatever procedure one does, be it a carotid surgery or carotid stenting. And Peter Ferry's presented some very nice data showing that patients on statins in the peri-procedural period have a lower incidence of embolic events. They had lower amounts of material in the filter when they had the carotid stent. So I think peri-procedurally giving the patient statins is a very good thing to do, whether they're having surgery or stenting. And as a matter of fact, there's evidence that now, which is very strong, that upping the dose of statins in patients undergoing a coronary stent decreases the morbidity and mortality. So I'm all for that.
Another short-term issue has been access. You know, years ago, I'm sure you were involved with carotid angiograms done with direct carotid sticks.
Yes.
Then we went transfemoral. What's your view in terms of access? Where are things headed?
Well, I think clearly they're headed towards accessing the carotid in the neck, because many of the problems with carotid stenting come from navigating the aortic arch and dealing with difficult aortic arches, which most elderly patients have. So I think the idea of accessing the carotid in the neck, either with a small open surgical exposure or percutaneously, I think will diminish the adverse event rate with strokes remarkably. And I think that's the way to go. Of course, it has to be proven, like anything else. And one of the things that's very upsetting to me is the fact that the reversal of flow device hasn't been, the GORE, specifically the GORE reversal of flow device, that Medicare has not approved that device, which has been proven to lower the incidence of strokes or adverse events in carotid stenting. And maybe the CREST group can make a statement that allows GORE to be compensated for making this clearly better device.
Well, we are working with CMS on this coverage under evidence development, which
Right.
I'm sure you're aware of.
Yes.
And with the FDA on being able to introduce new technology. Another question I had, kind of short term, we've had very good results with local anesthesia in CREST with regard to MI.
Right.
And you know, as you know, we had not a large number of MIs, but more MIs with surgery than with stenting.
Right.
How do we do better? And does local anesthesia, is this something that you think has a place?
That's a very interesting point, because as you know, there's some controversy as to whether local or general is better. And there were studies showing that the incidence of complications is equal with local and with general for carotid endarterectomy. I happen to believe the way to decrease the incidence of MIs with carotid endarterectomy is to use a high loading dose of statins perioperatively on all carotid endarterectomies. And the other thing that you showed in CREST basically was that, or I shouldn't say you showed, but which we observed in CREST, is that the possibility that the antiplatelet agents, which were intensely given in the carotid stenting, if they were given to carotid endarterectomy, which was proven safe this morning. There's a presentation from a guy from Lebanon on the fact that you can maintain clopidogrel dose during carotid surgery safely. That if you give comparable antiplatelet therapy to the carotid endarterectomy, you may lower the MI rate, and certainly the statins will do it.
I guess I'd say bottom line, stenting's getting better, surgery's getting better, our medical therapies are getting better. That's all good. For trials, that's tough because you have fewer events, which means you need more patients. And so the challenges are still there for us.
The challenges are still there, and that's good for our meeting because there'll always be new information and new controversy that has to be resolved, and dispensing that information and highlighting the controversy is really what our meeting's about. So it's
Very good. Thanks,
Okay.
Frank. Appreciate it.